Thank you very much, Dr. Angmo, for a kind introduction. Wonderful to see all of you today. It's lovely to visit your beautiful country. I'd also like to thank Professor Dada for inviting me to speak today. I just want to mention before I start that I do receive research support from Heidelberg Engineering, and I'll be talking about their anterior segment OCT device. So before I begin, a show of hands, how many of you use anterior segment OCT in your practice or have used it before? Okay, wonderful. Yes, this technology has rapidly evolved over the last several decades and has become quite commonplace in clinical use. The earlier time domain devices were slower, lower resolution, but now we have spectral domain and swept source devices that provide us with beautiful high resolution images of the anterior segment, such as this one. So this is a representative AIOS image, and we can clearly see here the cornea, the iris, and the lens. One structure that's not easily visible is the trabecular meshwork. And so in order to identify angle closure, we have to identify the scleral spur, which is the structure that sits directly posterior to the TM in order to identify angle closure. And here's a representative image of an eye with an open angle. Here the scleral spur is shown with the yellow arrow, and we can see that there is no contact between the iris and the intercorneal curvature anterior to this. This is an image of angle closure. What we can see is that there's contact between the TM and the iris anterior to the scleral spur, and this is iridotrabecular contact, also known as ITC. AIOS images can also be assessed quantitatively. We obtain measurements of the size, shape, and configuration of the anterior segment and its anatomical structures. But first, we have to segment the cornea, the iris, and the lens, and mark the scleral spurs. After doing so, can we obtain these measurements that inform us about the anterior segment? So I have two cases for you today, drawn from my own clinic, that illustrate how I use AIOS in my own clinic. This first patient is a 62-year-old Asian female who is coming with the question, do I need laser for my eyes? She's a dentist, she's seeking a second opinion about LPI, and she is asymptomatic. She has no relevant history. On baseline exam in 2021, she has 20/20 vision in both eyes with a pressure of 18 in the right, 19 in the left. She's a mild myope with an average CCT of around 590. On slit lamp exam, she's narrow by Van Herrick, has a trace NSC in both eyes. On gonioscopy, we cannot visualize pigmented trabecular meshwork in 3 of the 4 quadrants, but they do open on indentation to scleral spur in both eyes. And on undilated exam, she has a cup to disc ratio of 0.5 in both eyes. She has a reliable and full field in both eyes, and on OCT, there are no focal areas of thinning that might be suggestive of glaucoma in either eye. So at this point, I'd like to summarize the Zhongshan Angle Closure Prevention Trial, or the ZAP trial, which provided us with evidence for the management of this patient. This was a landmark randomized control trial that was published in The Lancet in 2019. And the purpose of this study was to assess the benefit of LPI for the prevention of angle closure. The ZAP trial recruited 889 bilateral primary angle closure suspects, all of whom were between ages 50 to 70 and mainland Chinese. And these participants were randomized to LPI in one eye and monitoring of the other eye. These participants were followed for 6 years, and the endpoint was progression to primary angle closure, which was defined as formation of PAS more than 1 clock hour, elevated IOP over 24 millimeters of mercury, or an acute primary angle closure attack. The ZAP trial yielded 2 important findings. The first is that LPI does work in reducing the risk of progression by around 50%. However, the other important finding is that the risk of progression is very low, even in untreated PACS eyes, which is the state of this patient's eyes. So the question here then is, this patient has PACS in both eyes. How do we further risk stratify this patient to decide whether or not she needs treatment? So at this point, we got an anterior segment OCT of both eyes, and I've marked here the scleral spurs in both eyes. And what you can see here is that there is no iridotrabecular contact in either eye. You can see zoomed in here is that there is still a slit between the trabecular meshwork and the iris that allows for aqueous to flow out of the eye. Also, we got a measurement of angle width in the form of angle opening distance, which is the distance between the trabecular meshwork and the iris. and this measurement was 0.13 millimeters in the right eye and 0.12 millimeters in the left eye. I know right now that doesn't mean anything to you guys, but by the end of this lecture, hopefully it will. So I'd like to, at this point, just summarize a study that my lab performed in conjunction with the authors of the ZAP trial that we published in 2022. The purpose of this study was to better understand the clinical significance of ASOCT measurements in PACS eyes using data from the ZAP trial. Here we took data from 643 untreated PACS eyes that had received gonioscopy and anterior segment OCT at baseline, and our outcome measure was progression from PACS to PAC. This table shows our primary finding. Here in this multivariable model, our measurement of angle width is angle opening distance, or AOD. You can see that AOD, adjusted for age, iris curvature, and anterior chamber depth, is significantly associated with progression. Specifically, for every 10 microns smaller in AOD, the risk of progression increases by around 10%. When we replaced AOD with gonioscopy score, which is a sum of the gonioscopy grades across the 4 quadrants, we found that gonioscopy score was not associated with progression. What this tells us is that gonioscopy fails to provide us with information about progression risk, whereas ASOCT measurements can help us perhaps risk stratify these eyes. So how do we apply this in our evidence-based care? Well, in the ZAP trial, the mean AOD measurement was 0.09. So around half of the participants had an AOD greater than this. And what we know is that our patient has an AOD that exceeds this mean, which means that in terms of angle width, they're in the wider half of the cohort. So this would imply that the patient is at relatively low risk for PACS eyes. We also know, based on other work, that the more ITC that we see in ASOCT images, the higher the risk for PAC and PACG, and as we saw, this patient has no ITC on their ASOCT images. So we diagnosed this patient as a low-risk primary angle closure suspect. We had a discussion regarding LPI, but the patient ultimately elected to monitor annually. She was given acute angle closure precautions. So we continue to follow this patient. Most recently, I saw her in May of last year. Her pressure remained stable at around 19, and the rest of her exam also remained very stable. Her visual field has been full, and her OCT RNFL thickness has been unchanged. So our plan is to continue annual monitoring, and we're monitoring her for elevated intraocular pressure or the development of a visually significant cataract, at which point we will perform lens extraction. So the second case is a 41-year-old Caucasian male who is coming asking, do I have narrow angles? He works as an investment banker referred by an optometrist for an angle evaluation and is otherwise asymptomatic. He has a family history of narrow angles, and his mother, who received an LPI and had an unpleasant experience due to dysphotopsias. So we see here that he's 20/20 in both eyes with a pressure of 17. He's a mild hyperope with an average CCT of around 580. On exam, the patient is also narrow by Van Herrick. Here we can't visualize any angle structures except on indentation, where we can see pigmented trabecular meshwork in the inferior quadrant. There is no cupping on undilated fundus exam. The visual fields are reliable and full in both eyes. The OCTs are thick and reassuring in both eyes as well. So these are the ASOCT images for this patient. We can see the scleral spur is marked in each image, and there is iridotrabecular contact in all of these images, implying that the angle is very narrow in all sectors. And also, we measured the AOD, which was less than 0.05 millimeters in all sectors. We got a UBM in this case just to see why this young man had such bad angle narrowing. He has elongated anteriorly rotated ciliary processes, which suggests he's on the plateau spectrum, and we also found that he has ciliary body cysts as well. So at this point, we were considering what we should do, whether we should monitor LPI or do clear lens extraction, and you can do this exercise in your own head. But here we decided that we needed to practice evidence-based care. So as you know, in the ZAP trial, the mean AOD was 0.09. This patient is narrow in all sectors below this mean value. and also has ITC in all sectors compared to our last patient who had no ITC. So we diagnosed this patient as high-risk PACS. We recommended LPI given these ASOCT findings. We counseled him about the plateau iris and the ciliary body cysts, and ultimately he was very cautious about LPI due to the negative experience that his mother had had, and so he deferred the LPI. And so I gave him acute angle closure precautions, and we decided to follow every 9 to 12 months. So fast forward a couple years, now it is September of 2023, and he comes in for the first time with elevated intraocular pressure of 24 in both eyes. The rest of his exam is unchanged. We can see here that his OCT RNFL thickness remains full and unchanged despite the change in IOP. So at this point, we had a new ASOCT device. Here you can see beautiful images of the entire anterior segment, and our AOD 500 is 0.03. So now you guys are all becoming experts about AOD. This is a very narrow angle. In the right eye and also in the left eye, it's 0.05. So here, the recommendation by the World Glaucoma Association, American Academy of Ophthalmology, and the Asian Pacific Glaucoma Society is that angle widening treatment is indicated as this patient now has progressed to PAC. There is substantial evidence suggesting that patients who receive LPI experience significant angle widening that can be measured using ASOCT, and we also know based on landmark studies such as the EAGLE trial that LPI can effectively lower intraocular pressure in PAC eyes. So here, this patient was much more amenable to LPI now that he had elevated IOP, and so we proceeded to perform the LPI in both eyes. Here we can see the angle widening benefit of the LPI. His AOD has gone from 0.03 to 0.12 in the right eye. And he didn't experience quite as much angle widening in the left eye, where he went from 0.05 to 0.08. Still, his IOP did come down after the LPIs to 18 and 17 and has remained stable. He was counseled about the possible need for clear lens extraction in the future if his pressure is to go up again. And we were following him more closely due to the residual angle narrowing despite the LPI. So here I'd like to finish with just one more point, which is that we have certain clinical gaps or barriers that prevent us from using ASOCT efficiently in our clinics. And one is that you need a certain amount of time and expertise before you can obtain these useful ASOCT measurements. So fortunately, we have access to artificial intelligence, or AI, which is a transformative technology that promises to change our daily lives. We use convenient tools such as ChatGPT to answer all of our questions, and large language models like DeepSeek have had profound economic impact across the world as well. So in 2020, my lab published this paper in which we automated the scleral spur detection in ASOCT images, which is the key step to getting these measurements. And more recently, we worked with Heidelberg Engineering to develop a similar algorithm for the FDA-approved Anterior ASOCT system. And so here we developed an AI algorithm using around 4,000 images that had scleral spur locations marked by an expert. And before we adopt this kind of tool in our clinical practice, we need to thoroughly validate it. And that's what we did. We collected 1,300 images at USC, and we marked 2,600 scleral spur locations. And this scatter plot shows the agreement between two humans. This error is calculated as the reference minus the predicted scleral spur coordinates, and we can see the median error is around 60 microns. Here's the agreement between the human and the machine. You can see the scatter plot looks very similar, and the median error is also similar at around 56 microns. This table shows intra-class correlation coefficients, which measures the amount of correlation between two sets of measurements. In the left-hand column, it's the agreement between an expert grader and a glaucoma specialist. And we can see that these ICC values are all very close to 1, which shows that there's a high degree of correlation between two human graders. This high degree of correlation is matched by the human and the machine, which also shows very high ICC values for all parameters. What this means is with a simple click of the button, we now have access to expert-level measurements, making this technology more accessible. So in summary, ASOCT imaging can be very useful for the care of our angle closure patients. Recent research helps advance evidence-based care, And AI makes this technology and ASOCT measurements more accessible for busy clinicians. However, we still need further advances and research before we can widely adopt this technology for the care of our angle closure patients. So thank you very much. It was a pleasure. I'd like to acknowledge the hard work of all my lab mates, and thank you for your attention.
That's a very nice presentation of objective assessment and to see the progression of PACS in the clinical course. So you think the most important parameter which I could understand from your studies, AOD 500. If depending on AOD 500, you plan the further the treatment strategies, whether to do LPI and or to do clear lens extraction. Is that so?
Yeah, that's a great question. So I mentioned AOD 500 in this study because, or in this context, because in the study that I described, that was the most predictive of progression from PACS to PAC. We find, though, that depending on the outcome measure, whether you're looking at progression or IOP, sometimes the exact measure of angle width, the parameter describing angle width, can vary. So sometimes it can be the area in the angle, sometimes it can be angle opening distance. So this is something that we're still working on in the field to figure out which one parameter should we be using. But AOD is certainly very easy to measure and understand.
Doctor, how about the exact, determining the scleral spur, because I think that's the main point. So how are you sure that you've been able to go on to the scleral spur?
Yeah. So in the scatter plots that I showed, one of the graders was me, and then I have a research technician who's graded over 20,000 images, bless his soul. And so we really wanted people who were experts in identifying the scleral spur to be the reference, to be the comparison. And I think given that the agreement between the machine and the human matches this and is actually a little bit better, I think this gives us a high level of confidence that the algorithm is working very well. And we need to make sure that it works well because we're going to be using it in clinical care.